My name is Dr. Jeremiah Laichena. I'm an orthopedic surgeon from Kenya. I'm going to present you a case that we did yesterday here with Dr. Chapman. So this is a patient, LP, 79 years old, who was a metastatic lung adenocarcinoma that was recently diagnosed. The patient presented to the hospital around a month ago, almost a month ago, with complaints of pain on the right upper limb that was actually radiating or down the spine as she was explaining it. And she was saying that the pain was more on the lateral side, and she was feeling the discomfort around the hand, and she could actually say it was just around C7 and C8. The same patient has had an issue like around 6 weeks of incontinence and 4 weeks of loss of control of stool. As a patient with no previous cancer history, positive smoking history, and worked in radiology, known to have bipolar, emphysema, hypertension, and high cholesterol. So initially when the patient came, because of she was having myelopathic issues, so the need for surgery was discussed, but she wasn't keen on that, and she actually went home and came back like 3 days ago again, complaining that the pain was actually becoming much worse, and because of that, she said that she couldn't live with that pain anymore. So our initial presentation, though myelopathic, that's what we had. Most of our motor H score was good in most of the in the upper limb and the lower limb. But now when she came 3 days ago, this is what she had now. She was having weakness in the finger abductors and also on the elbow extensors, and she had a positive Babinski on the left side, and she said that she needed to be sorted out. So the right upper limb, there was numbness on the right upper limb and the right lower limb, but bowel function was normal. So when she came, these were the initial images 1 month ago. You can appreciate a lytic lesion at around the posterior elements of the 6, C6, C7, and also T1 on the anterior elements. So that's the CT scan, and you can also be able to appreciate that, especially with contrast on the image on your right. You can see the involvement of the C6, C7, and T1 quite involved, and that's another scan just to show you both sagittal, coronal, and the axial images of the involved levels. Can actually see that this is looks more like an impending central cord syndrome, because even just braking on the road or fall or any turn with such lytic lesions can easily bring out disaster. So you can see that on the axial image, as the involvement of the exiting nerve roots, and especially more on the right side. And then, so that's what we had. And like I was saying, it's more of an impeding problem. Yep.
So somebody in the beginning lecture who's sitting to my right said, biopsy, biopsy, biopsy. We don't have an acute neurologic problem. Having been involved in her care, we slow walk this. There are a lot of factors involving her. She lives alone. She used to work in the medical field. Chain smoker in the past. Very, very kind of decisive personality. She has bad neck pain. She's not fractured. I think her SIN score was 9, something like that.
Yeah.
Neurology not overwhelming, no myelopathy really. She lives in a neck collar, and we've done 3 steroid courses on her. She's only halfway happy with steroids. We've given her membrane stabilizers, max dose. We've given her narcoleptics. We've minimized, but we've given her opiates, and the dose has crept up. So she's only happy with a collar and all that. So we did a biopsy, and it shows adenosis of the lung. She has a sacral lesion also. She has a skull, but no brain lesions. How do we quantify what she has disease-wise versus what, good man, a big sacral metastasis also, no pelvis fracture. How do we kind of approach this patient now? So she has a will, she has a mind, she's a very feisty person. shall we say. But there's a lot going on here.
Am I the next one? All right.
You're the one who told us biopsy. We biopsied her.
Well, but she had,
To the OR.
but she had a history of non-small cell lung cancer before you saw her, or no?
No.
Okay.
De novo. We had to wait.
Oh, okay. Yeah, the usual. Yeah.
We had to wait for about a week until we had everything
Yeah.
together. She has
That's a
a
problem.
number of mutations in there, so there's some things. There's a whole printout, but it took about a week until we had something meaningful back.
Okay. I was a little surprised when you said initially, before I saw this image, when you said that she had some issues with her bladder, because there's no indication on her cervical MRI to have any bladder problems until I saw this image. And so I think when you have somebody who has no cord compression and they're coming in with urinary problems, you got to look somewhere else, because it's not coming from that. It's coming from something else. And clearly there is involvement of the sacral nerve roots there. So I think there's two issues here. One, you get the bladder issues. I don't know if 3 weeks after the bladder issues have resolved. And secondary, you got a patient who has mostly radicular pain, maybe some neck pain. So in this particular case, it's important for me to differentiate mechanical pain from radicular, from a non-mechanical pain. And what do I mean by that is, if I don't see a fracture, and in this particular case, I don't see a fracture, there's no fracture of the vertebral body, then it may be that she's getting a little better with a color, but I think the majority of her pain is related to the tumor within the vertebral body causing her pain. That is what I call biologic pain. It's tumor-related pain. If there was a fracture there, then any movement of the neck, flexion, extension, rotation, any movement-related pain indicates to me some mechanical instability, and I'd like to correlate it with seeing a fracture. Not seeing a fracture here, I would bet that significant portion of her pain is coming from just the tumor is in the vertebral body, giving her a lot of pain. In that sense, there are really few options. One is, this is not a radiosensitive tumor, but it can respond to radiation. It also depends on what kind of non-small adenocarcinoma it is. There are now major evolutions in patients with lung cancers where there is a lot of adjuvant therapy options. We used to think no, now there is. So some of the receptors on those type of tumors can make a difference. There is a big lytic lesion there, and yes, you may have a risk of a fracture there. I can't tell if it's like how much of the body is actually involved. If there is a space, enough space between this tumor and the thecal sac, sometime a myelogram will tell you, then radiosurgery could be a very good option here. Why? There is no cord compression, there is no pathologic fracture, and the radiation will help with a lot of the pain symptomatology. That's option one, especially in a patient who may be very resistant, doesn't really want to do the things that you want to do. Surgery is also an option, but there's no small surgery here. Decompression, both the canal and the nerve root. I'm not sure that there's any need for anterior column support because the vertebra is not broken. There is a big lytic lesion there. Theoretically, you can fill that space from the back if you're going in through the pedicle and put some cement into that defect just to give it some mechanical support. I will not do a back front surgery or anything like that, though it's very tempting. So it's just kind of like in general the way I see it. I think the other issue is you have a big sacral lesion that is symptomatic. It does cause some bowel bladder issues that also needs to be addressed with likely radiation if you're already planning on doing surgery there. So theoretically, if I would go with radiosurgery, I would treat both at the same time. That would all change if there's pathologic fracture. That would all change if there is cord compression. There is no cord compression here. And so a lot of time I find that the radicular pain symptomatology on patients with METs harder to deal with because many times you can't get around the entire nerve roots. You do your foraminectomy, but there's still a lot of tumor from underneath maybe wrapping around the vertebral artery. And so radicular pain symptomatology with surgery, sometimes it works, a lot of time it doesn't. Many times surgery on the cervical spine has to do with decompressing the cord to prevent further deterioration on the other arm or prevent deterioration in the legs. So that's just kind of like in general the way I think about cervical meds.
Yeah, I mean, I think those are, I think, Udi, that's a great way to think about, treating this patient. There is, like you said, it's a big lytic lesion. But, I think I probably would consider radiosurgery. I know, for someone like this, she's got the sacral mets and she's kind of, I think you guys said she left the hospital, then came back. So, I mean, I think this is a good patient to get. I'm sure I know you did this, Jens, but palliative, and then kind of figure out, what does she want, and then what's going to be kind of most reasonable for her, given the fact that it is lung CA. So
I would only end with the radiosurgery. It is a candidate. There is a candidacy for radiosurgery here. Again, why? No cord compression. There is CSF around the cord. There's no fracture. The only thing about radiosurgery is that there is a risk of iatrogenic fracture after the radiation. This is a high-dose radiation. She has a large lytic lesion there. And so that's the kind of conversation that you have to talk to the patient about. We can go the non-surgical route, do the radiosurgery. There is probably 30-40% chance of maybe a fracture evolution. You may keep her in a collar for a couple of months to try and minimize that fracture to happen after the radiosurgery, and you just watch it carefully. If she doesn't want to take the risk of that potential fracture, then surgery is an option.
Does the SIN score help you?
Not in this one.
Why not?
It's low, but again, you have to look at the patient, and patient wants to be more active. She's with it. She has come to the hospital multiple times. Seems like some patients, I'm not sure about this one, in terms of collar, some patients don't tolerate collar well for a long time, especially that she's going to be in it for a while. So SIN score doesn't help me, but if she wants to be stabilized, I think it's reasonable to stabilize.
You and Zia and so many others were foundational in the SIN score. Why is the intermediate range so huge? This is a typical intermediate kind of a cage. Why did you guys make it so very big? If it is intermediate, almost.
Yes, because these are the cases where it can go either way, right? And so in many ways, I mean, one of the things that is concerning here is the facets are involved. So first of all, the lytic lesion is not at the same level of the facets involvement, right? There are two contiguous levels. But yes, the intermediate SIN scores are always could be somewhat problematic with these cases.
So let me ask another question then. So Dr. Mean has now come out. That was a great lab. So have a fresh set of eyes. I don't know whether you heard the case description. Proceed, 79-year-old lady, metastatic lung CA adeno variant. We biopsied her. We tried to treat her non-surgically, brace, meaning collar, steroids ×3 now. Sorry. Membrane stabilizers, opiates. She is not happy. Dr. Osgoyan suggested palliative care, very helpful. And then he wanted to do radiosurgery. So I'm sitting here on the right wing now. And to your left is a hyper-aggressive young surgeon. She has a sacral lesion also. She probably has some bowel and bladder compromise from this. Would you veer towards surgeon? We heard Dr. Gokazlan, one of my other favorites, say there's no way to do any form of radiation here in this highly mechanically susceptible zone without getting a much higher risk of wound healing problems. So where do you lean to? Surgery, you suggest surgeries?
Yeah, I think for us, using like the NOMS criteria and framework, we would basically say, okay, this is potentially mechanically unstable. They're clearly symptomatic in terms of neck pain. So we would at least try to do some sort of open stabilization. And it looks like we're getting close to the cervical thoracic junction there. So
Can you put the MRI up there?
So no percutaneous screws at the cervical thoracic junction?
Not yet. That's like the next phase. But yeah, so I would typically go 2 up for the lateral mass screws above that, and then I would try to do a separation surgery where we would at least do a wide posterior decompression, and then of course in the cervical spine it's going to be difficult to kind of go around the cord with eloquent nerve roots and not much of a pedicle to drill down. So, but typically if we get like a pretty wide laminectomy, I would just kind of go a level above and level below with the laminectomy as well. I do often see that the spinal cord will kind of float back because of the lumbar lordosis, and so if you really ensure you get decent lumbar lordosis with your construct, the cord may float back from that the rest of the tumor in the vertebral body, and then hopefully we can radiate the rest.
Dr. Lightenite, so you come from a very competitive city there in Nairobi, many different hospitals, and this patient used to work in the medical field, assume she is insured. What would you do with this patient in Kenya?
I would decompress. One of the reasons, like I was saying, this is like an impending doom. This patient turns, or we have a lot of road bumps in Kenya. She jumps a road bump using public transport, and the neck will just to be more of a palliation. I think I would decompress and stabilize.
Okay.
Yeah.
Shall we go ahead, or do you want to comment anything else? You've not actually said what you would do, right?
Yeah.
So we followed your playbook so far to the T. We
Yeah.
biopsied her. We got palliative care. We listened to Dr. Oskuyan. We sent her home several times. She's come back a third time now.
Yeah, I think I would not have tried steroids on her. I think that if you decide you're doing surgery, then do the surgery. Decompress the nerve, do the fixation. It will help with the pain and all that stuff. I think you may buy some time, and part of it you used it because she was giving you a hard time going on with what you probably wanted to do up front. I would go on with a biopsy, get it done, wait. I guess you had to wait a week to do it, and then just fall on one side or the other. For me, if there is an option, again, it's an intermediate zone. The lytic lesion is not at the same site of where the facets are involved. There could be progression. If it's a non-reliable patient, it's not going to come back and follow closely. I would do what exactly, I think it's fine. If it's a patient who really is very much resistant with surgery, and there is an option for radiosurgery here. It's not an unacceptable option. And she's somebody who will come to clinic in 3 weeks, going to keep her collar on and give an opportunity for some healing. I'm okay with giving it a shot. Again, could it break? It could. There's lytic lesion at C5. There is facets involved at C6. But with time, with somebody who has the collar, this could heal. There could be some bone growth that get placed on bone strengthening agents. The oncologist would like to treat it very quickly. You're doing the surgery. Now you have to wait a couple of weeks to allow her to heal. You're holding off on the treatment. You're going to have to hold off on the radiation. She's going to need radiation after your surgery. You got to hold off on that. So by the time you're done, you're looking at 6 to 8 weeks before you even can start treatment for this. Again, go back to the first statement I said. It's easy to look at this and say, I need to decompress and put the screws in, and that's great. I agree. But what comes after? You have to wait 6 to 8 weeks. People say 3 weeks. I think it's too early. I think, at least 6 weeks to wait with the radiation and the chemo. And those oncologists are going to be on your doorsteps. Can we start? Can we start? Can we start? Can we start? And so all of that has to be come into this consideration. That's why we have a tumor board. I am okay with radiosurgery. I'm totally okay with decompression and fixation with a cervicothoracic fixation. Why are you doing it? Well, because you're worried that it's going to break. Are you doing it for the radiculopathy? That doesn't help a lot of time with these type of surgeries. You're not going all around the nerve roots. As I said, there's a lot of tumor in the foramina that's going to stay there. So you need to treat that with your radiation. You need to treat that with your adjuvant therapy. If there was cord compression, the main purpose is to decompress the cord. I see many patients who come in and the tumor involved the nerve root around the vertebral artery. You can't take all of that out. You need to treat it with adjuvant therapy. So I think those cervical cases with radiculopathy are always trickier than the straightforward pathologic fracture and cord compression.
Should we move forward? Drum roll. What do we do?
How about the lumbar?
The pelvis, yeah. So let's bring that up. So let's just assume that after palliative care and after iterative discussions with the family and the patient, we've decided to possibly move ahead with the cervicothoracic spine. Should we do the sacrum at the same time, or should we rely on the radiation magicians to help with that?
Honestly, I think this is why I had a hard time operating. But I think if you're going to operate, the difficulty for me is trying to figure out what whether the bladder issues are from. I think they're coming from this. So I don't know if I would necessarily have operated on the cervical. So maybe I disagree a little bit with Udi. I probably would have radiated this and then see how she did, and then actually then come back and be aggressive and put carbon fiber and screws with cement. That's my, because then I think, then you rule out, because I think that's pretty bad based on, just the sagittal CT. That does not look good.
Yeah, there's an MRI also. Neil?
So in terms of cervical spine, there was some T2 signal change, just some, not significant. But if you were thinking of doing something with the sacrum, what are your thoughts on positioning the patient prone, intubating the patient, and et cetera?
The lumbopelvic junction is stable. S1 is intact. The pelvic ring is intact. So S1 is the key vertebra there.
But cervical stenosis and intubation and prone position for a while you're working on the sacrum?
Yeah, I mean, for me, clinically, without a question, the overarching problem right now is the severe pain of the patient. If she puts her pain list together, the first 7 to 8 spots would be all neck pain and severe radiating arm pain. She literally has a protective posture. She has a neck collar. Jeremiah is on rounds for a good bit. So that's her clear number one goal. The number two thing is, my pelvis can't function quite right there. I hurt somewhat, but that is easy for me to take care of. But my first priority would be hers also. It's the cervicothoracic junction. I would feel uncomfortable doing both together at the same time, I must say.
Agree.
I don't know, the staging, I told her we'll probably have to do something for a sacrum, but we'll probably wait for a while for the sacrum for maybe hopefully less than a week. She's very feisty. That's in her advantage. She doesn't have any overwhelming medical problems. So, Jeremiah?
Yeah,
Hold
she
on, hold
said
on.
she can't.
Let me make a comment about this.
Yes.
You guys can see exactly what I'm talking about right here, right? When it comes to what are you going to do about this? We are focusing on the patient's pain in the neck. Okay, but what is the major issue here? Radiculopathy with some pain in the hand. At the time that she was seen, there was no weak. She was 5 out of 5. But she's incontinent, right? She was urinary retention. What was the initial symptoms?
Yeah, she said that it's not there all the time.
Yeah.
She says sometimes when she just stands up,
Yeah.
urine just, and
It's a neurogenic bladder. It's a full
Okay.
bladder.
yeah.
Yeah. So is it coming from this mass, this neurogenic bladder?
Possible.
Yes.
Sitting down, opiates. This,
Yeah.
this is clearly a problem.
Yeah.
Without a
So
question.
some of these bladder issues very likely coming from this. What's more important? So the patient says, I'm having neck pain, I'm having neck pain, I'm having neck pain. But what is really important here? Because if she's incontinent, that's going to be a much bigger problem for her down the road. It's not the pain. That's where I'm getting into this. What the patient wants is one thing, but what's the difference between somebody who comes in and says, I have urinary problems, incontinence, versus a Cauda-Equina syndrome on a patient who comes with a disc? You're going to be going very quickly to take the disc out to help with that, some urinary issues. But here it's like, well, but you're having this other stuff in the neck, so we're going to treat your pain. I think you got to think about this very carefully. The patient could focus on the pain, but you also have issues with bladder issues, and it's related to this. All of the sacral nerve roots here are completely and these are the sacral nerve roots that innervate the bladder. I believe, could it be from opioids? Yes. Could it be stress? Yes. But it's also very likely that it's coming from that. You can do the biggest surgery that you want with decompression and all of that, but if the patient is incontinent, the patient is incontinent. So for me, treating this at the same time or not at the same time comes with the question of how long has it been? If she's presenting with incontinence for 2 weeks, okay, the cat is out of the bag, because now the likelihood of you going in there and decompressing it and restore it is not high. And in that sense, I'm focusing on the neck. But she's coming into your clinic, or she's coming into the ER, and she's incontinent for 24 hours, and she's complaining of neck pain. What would be your priority, fixing the neck pain or dealing with the incontinence? So I think that's how I see that. Saying all of that, this lady have been presented with a couple of weeks of incontinence, I think, or whatever. And it's amazing that she doesn't even care about that. That's right. That's because they're focusing on the pain. But in the long term, that is what's going to get her. That can be treated 2 weeks out with radiation. Go back to what I said. Maybe there's a role to do radiosurgery to the top and radiate the bottom. The radiation will help, no question about it, to the neck, because there's no fracture here. A lot of the pain is coming from tumor compressing against the dura a little bit, and there is biologic pain symptomatology. But if you go ahead and you do the decompression, I would do the decompression and I would radiate the sacral lesion. You don't need to wait for it. It's away from your surgical field, and you can do it while the patient is recovering from her neck surgery. The radiation to the neck surgery will come a couple of weeks later.
The first time the patient came, February 19th, all these problems were there and she didn't want any form of surgery. And so she went away and then came back now 3 weeks later. And this time she came saying that she cannot live with a pain on the neck and her hand. And she had already stayed for out over 3 weeks with a bladder.
Yes, but again, you're
issue.
focusing on the pain. What about her bladder? When she came 3 weeks later, was she peeing okay?
It was
Or
still
she was incontinent?
It was still the same.
She was
Neurogenic.
incontinent.
Yeah.
Yeah. So I think that is, in my mind, that's something that needs to be addressed. I think it's too late now, a couple of weeks after all of that. And in that sense, I will not see the need. I will go ahead. If surgery is the way to go, we're doing the surgery. While you're waiting, you let her recover, go ahead and radiate the sacral lesion.
All right, great discussion. Very good points, all of them.
So Udi ended up going with my recommendations. He wanted to radiate, then operate.
Yeah.
All right. So what did we do?
This was yesterday. So we operated. So this is what we did. We stabilized from C2 to C2 to T4 with lateral mass screws on C3 to C5, and then we skipped the right side on the C6 and T1, and so this is what we ended up with. So what we found in trial, the posterior processes of C6 and 7, they were just very soft and boggy, and we couldn't really have anything to put on the pedicles of that. And just to make the construct stronger, we used strut grafts. We used fibular strut grafts, and that helped a lot with the mechanical stability. Yeah, so that's what we did.
That's more for biology if she survives. So this is just a nice coverage of the large dural area, and we just cable it into the spinous processes. So she has a theoretical, I've seen these actually heal, believe it or not. So a lot of hardware. We didn't have any carbon fiber. We had the bone rods. We have something better than carbon fiber. We have bone rods. What do you think of those?
I would not put it in. I think you say we put it in there to give it more strength. This is already very strong. I'm not sure you need to put any more, but maybe for the chance of fusion down the road, hopefully that's going to work. But with her presumed radiation, as we spoke already, the likelihood of her fusing is very low.
Okay.
Too aggressive? Neil, you're Mr. Aggression.
No, I think the lordosis looks great, so cord must have fallen back, which is great. The use of bone, at least those grafts covering the dura, is a cool idea. Never seen it before. I love it. And yeah, overall, if this is what's going to hold her together because she's not going to fuse, then I think this is going to sustain her for a while.
So the gratifying thing was on rounds, she had literally no arm pain. She had some numbness and she said, why does she have some numbness? She has full motor strength, I kid you not. But she's going, why do I have some numbness in my fingers? I went like, you're looking at it. But actually Dr. Minnesali and Dr. Hogsett did a beautiful job with it also. But the neural dissection was actually easy. We did complete lateral mass resections down to the vertebral arteries on that side and just followed the roots out. I think 6, 7, 8, upper end of 1. Totally freed them up. So she only had numbness. That arm pain was gone. I was personally impressed, and this is again one of the problems of the SIN scores. She literally, I mean, that cervicothoracic junction was unstable. He showed you very nice images. Yeah. We didn't appreciate instability there, but she told me that she has instability with her face. When she would lay down, she was okay. When she had a soft neck collar, she was okay. The second she got up, she went into this kind of a weird position.
It could be micro movements, with this big lytic lesion that she has there, and that's what's doing it. Again, I think it's reasonable. I don't know if I would have put such a significant construct there, but I think it's absolutely reasonable.
You got to go from the front. I'm with you.
No, you don't need to, but you got to cross the junction for sure. I think maybe going down to T2 is probably where I would have stopped. But yeah.
So a lot is being said now about carbon fiber systems and all that. The rods are probably less important, right, Neil, than the screws. But there's a lot of different hardware. We use 2 different hardware systems here. We use the thoracic one, we use the cervical one, we use largest possible calibers in both. How do you see carbon fiber helping us here? And how do you see possibly in the future rods here? This is a pretty complex bend that we did here. I don't know whether we can have that predicted somewhere, and I don't know whether we have screws that can hold these angles that we put in there. There's a CT that actually looks, I mean, Dr. Hogsett and Dr. Minnesota did an absolutely beautiful job putting those screws in. They look perfectly placed, but I'm not sure how we can make that better with carbon fiber. I don't want to be a doubter. What do you think, Neil?
Well, what did you do with the anterior column? Did you
Nothing.
put cement
we used
or?
More. We put cement into T1, into the T1 body. We just like what you said. We cored it out. And we stuffed cement in there, open, like Perfect. What you said. But we didn't do anything in the front because, again, although one of the vertebrae was like 80% eaten up, it's not fractured. So we invested more levels posteriorly with a more rigid construct rather than doing a front and back procedure.
Right. In terms of cervical pedicle screws, to have a shorter construct, because you did beautiful C2 screws, but could you have done shorter construct with cervical pedicle screws?
I could have. I'm not a huge fan of subaxial pedicle screws for some reason.
So I do think that for a case like this, I do think, the bone quality didn't look good. I think, Jeremiah, if you can show, I do think there's a role for carbon fiber in something like this. I do think that, do you need to have a rigid, long titanium construct on something like this? I do think it does set you up for potentially some adjacent other disease. So, and again, I mean, I think the construct, I think for me, for mostly, like this patient's going to get radiation. So I think this is a good example of, maybe carbon fiber is not a bad option. So
I would add that you went all the way up to C2 because C2 are the best screws that you can put in there. The lesion is at C5. I think that one way I start not doing that, and I know you do it a lot, Jan, is I just put bicortical screws at C4, C5. I put very long screws. So I'll measure it, and I'll go in, and I'll drill 14, 16, 18, 20, 22 until I break through. And by putting bicortical lateral mass screws, it's been very successful to the need to go all the way up to C2. And I compensate for that by doing that. Don't go short, go long. Measure it, pull your bolt tip probe, make sure you break through the other side, and then put the long screws. The other thing that I like to do on these is I like tapered rods. I don't like the 4 millimeters going all the way down. I spend times on the carpentry making sure that the screws are all aligned, so I don't need to use cross connectors and all that kind of stuff. Remember, the lateral mass screws are going medial to lateral. The thoracic screws are going lateral to medial, so by default, it's never going to be aligned perfectly right. But you got to make sure, and I tell this to the resident, in order to get a tapered rod where you have a 5.5 on the bottom and a 4.0 on the top, cheat a little bit on your lateral mass screws on the top, put them a little bit more lateral. So instead of your entry point being in the middle of the lateral mass, go maybe a millimeter lateral, because you want those lateral mass screws to be aligned with the lateral thoracic screws. They're going lateral to medial. So typically, if I plan on using tapered rod, I'll put the lateral mass screws a little bit more lateral and the thoracic screws a little bit more medial. And if you pay attention to it and you just don't just go and slam the screws, you will get a tapered rod. And I really never had any failure with having a bigger rod on the bottom and a 4 millimeter rod on the top.
Yeah, this is a tapered rod construct here. Anu, did we go too aggressive, too long? Is that that's excessive? C4, C3?
Yeah,
Is that by or something?
Now, I think I would also consider cervical pedicle screws. Usually what I'm doing now is I'm just looking at the CTs preoperatively to see, can I fit a reasonable pedicle screw in there or not? And so if I can, then I may do a shorter construct.
Especially with navigation, you can definitely navigate the screws through the pedicle.
I just had some minor points. I think we definitely could have gone shorter if we used cervical pedicle screws on the top of the construct. I think the length of the construct in the thoracic spine was very much due to T1 had pedicle involvement. We knew that we were going to do wide decompression up to at least T1, including pedicle. And so I think stopping at T2 was definitely a bit concerning, knowing she's going to need radiation. And I think that's why, in the thoracic spine, why we went so distal. But I think those are great points about the proximal portion of the construct.
I'm going to hypothesize that her quality of life at age 79 is not going to be affected in 1 iota if we stopped at C4 versus C2. The chances of a hardware failure are way higher. And having had a vertebral artery with a bad outcome, I'm really a little bit worried about subaxial pedicle screws again.
So I also don't use, if I have it, I prefer not to use it if I don't have to. Only when I absolutely have to, I do. If I have to cross the cervicothoracic junction, I skip C7, I put lateral mass screws. I always put long lateral mass screws. I always put them bicortical. I don't think there's any, just spend the time, drill deep, break to the other side.
Look at those lateral masses. They're like they're Ehud Mendel.
Yeah, you wanna put them long, and sometimes you can use the 4 millimeter screws instead of the 3.5 or even the 4.5 millimeter screws, in order not to go all the way up to C2 if you don't have to. But clearly C2 is your gold standard, right? If you want to go up there, you're going to get very good either power screws or pedicle screws there, and then you're secured.
All right. Anything else to discuss about this case?
Yeah, to your question, so for carbon fiber, if you're not in the vertebral body, that's pathologic, right? Because your screws are not in the vertebral body, that's pathologic. And if you know that the tumor is in bone, it's bony mets and not epidural disease of any kind, then is there an advantage?
That's my question.
For carbon fiber?
Right?
I don't think so.
This is equivalent to a carbon fiber construct, right?
Yeah.
I think.
The one thing I've learned, and this is again how important it is to do something like what you've created, so many thanks to you, interdisciplinary communication is essential. I did not know until about 5-6 years ago how bad cross connectors are. The radiation oncologists hate cross connectors because they literally are usually put right over the mass decompression. I've done that in hundreds of patients, probably mindlessly obscuring or scattering their radiation beams. So just something simple like not putting your cross connectors, which I think are very important mechanically, and prevent this windshield wipering, is a really big deal.
Yeah, absolutely. Or if you have the fields unsecure and you need to put them away from where the lesion is, like on the bottom and way on the top, not where you just did your decompression. Yeah.
Great. All right. Jeremiah, anything else from your end?
No, I'm good.
Thank you for a nice presentation.
Thank you.
You want to join us here, Jeremiah? And Dr. Mendel has a case? Or
I have a case, or
what are we doing next, Corey? You're the real boss.
Yeah, if we are out of time, then we can move on to the next. What time is it now?
Corey is our
3:30?
next person
Do we have
waiting?
time?
Yes, but we have to take a small break before we go to our next person. We do.
Okay.
So I can pull up what Dr. Mendel.
You want to go on another case or go to the break?
Do another case. Finish the cases, yeah.
Okay.
This is a 59-year-old who's been having a history of progressively worsening low back pain over the last few weeks. She had a minor motor vehicle accident that she described 3 months earlier that started all this low back pain. So to make it, just for the sake of time, she comes to the emergency room and they ended up getting some plain x-rays. Again, motor vehicle accident about 3 weeks ago. She said all this back pain started after the motor vehicle accident. She comes to the ER, the back pain is severe. Neurologically, she's completely intact. Walking, just a lot of back pain. So the emergency room, go ahead and get these x-rays. You see this fracture on the x-ray, and you go ahead and order a CAT scan, and he calls you and say, hey, she's doing fine. We think we're going to put her in a brace, send her home, and then you can see her in clinic or something like that. So I'm just want to take it from here. What do you guys want to do?
MRI, look at ligamentous injury. I want to see the conus. I want to see how much compression there is. Yeah, I think this is significant in terms of kyphotic deformity that I want to do something about, at least more than just brace her, especially because she's so young.
Again, neurologically intact. Her main issue is pain in the thoracolumbar junction. You don't think she can go home? I mean, she's fine. MRI will take a while. Are you ordering it emergent? Are you admitting her? Because they tell you if it's not emergent, it will take a couple of days to get it.
How old is she again?
She's 59.
MRI.
MRI. Anybody else?
We are the spine service. MRI.
Emergent, urgent, routine. You're
Urgent.
admitting her? Urgent.
Not leaving the hospital. This is an L1 pancake vertebra. I always think the host responses are so great. So there is obviously a reactive heterotopic ossification taking place. There's some margination. So this patient has struggled with this, but this is an eminent ligamentous lesion. I play with my density and check out the canal occlusion, but this is conus area. I'd absolutely not feel comfortable letting this patient up with getting advanced neuroimaging.
Does anybody, now I know this is a spine tumor conference, but just keep that out of the picture for 1 second. She has no cancer. She had an accident. She's having pain starting after the accident. Is that looks like traumatic etiology or something else? Just based on that, I know.
Doesn't look like, it looks like a pathologic fracture.
Okay, Rod, explain. What here tells you that it may not be necessarily traumatic?
Just because you can see parts of the vertebral body, but on the CT scan, there's essentially like nothing there. Like you would think, okay, vertebral plana, you would still be able to see the end plates or some parts of the vertebral body itself, but you don't really see that. So that kind of makes me think of, okay, this might be something more neoplastic.
Okay.
So,
Neil?
It definitely doesn't look like a classic like flexion or distraction, right? It looks like the square broke in a coronal way where it went one twisted over the other. So I'd love to see a AP view, but it doesn't look like a classic like seat belt and just flexed or distracted.
It looks like a
MBA.
sleeve.
I'm sorry?
It looks like a sleeve.
A what?
A sleeve. The way, it doesn't look like a typical, what you'd have from trauma, maybe like a compression, because you can see that anteriorly, the cancellous part is just separating from the cortical lining. So it looks like something that has been there.
Here's the MRI. Yeah, and you wanted it. Here it is.
I'll ask Dr. Anu.
Sure. So we have the T2 upper corner there, and you can see that there is some retropulsion of the posterior elements with probably epidural tumor compressing the conus over there. And then I presume this is an axial cut over here. Is it? I'm not sure if that's T2, but if that's T2, I don't see any CSF there. So high grade conus compression there from this lesion.
Okay. Anybody else have any comments? So this is Christmas Eve, Friday midnight. The resident saw in the emergency room, neurologically intact. Do you guys get called by the residents here for somebody who's neurologically intact, who's just getting an MRI? Do you get a call?
We get called for anything. We get called for diarrhea. We get called for dysuria. We get called for whatever you can think of. A sneezing attack.
Okay.
They get MRIs on everybody, and that's a fact. Right, Dr. Gold?
So typically, right, a lot of times the patient is neurologically intact, has a fracture. A lot of times the patient is stable, will wait till the MRI is done so that when they can call, they tell you, listen, this is what the MRI shows, or should we get an MRI emergent, not emergent, because otherwise, neurologically intact, they can get admitted, MRI done in the morning. But it seems like all of you said, I don't like that. We're not waiting till tomorrow morning. We're getting not right now. Is that
I
correct?
think Neil said he wanted to wait.
Oh, I want to get a post-void residual since I saw the big bladder.
She's neurologically intact. There's no issues with bladder.
There's a big bladder.
that's a huge
There's a
bladder.
big bladder.
Yeah.
Come on. Dude, there's a giant
Yes, of
bladder.
course. But again, the patient did not complain of any problem with her bladder.
This is why a chaperoned
Yeah.
rectal exam, a digital rectal exam, and post-void residuals are necessary. And I would have an extremely low threshold of giving this patient a Foley catheter and a bladder decompression.
Okay. So anybody else have any comments from the audience? Residents, fellows? All right. So MRI is done, and the tech is going to get the patient off the table, and the patient is not moving her legs in the scanner.
Wow.
Is that explained by this? Neil?
Maybe the positioning.
Maybe?
Well,
Yes or no?
yes.
Yes,
100%.
okay.
Yes.
Neil
So-
didn't want to get the MRI.
So the patient went from walking to the emergency room to going down to get an MRI, and as they're trying to pull her out, she's now not moving her legs. That's the scenario.
Is there a sensory level?
There is a sensory level,
What is the sensory level?
right at that level.
Okay.
So she is, there's no cancer diagnosis, there's no diagnosis, other than she had an accident 3 weeks ago, started having back pain. That's all we know. Now she's coming off to the stretcher. 0 out of a resident goes down to examining her. Legs are not moving.
And areflexic in the lower
No
extremity.
reflex, nothing.
Yeah.
0. Now,
I mean, this is a great case for a scanning or a scout sagittal MRI, brain,
Yeah.
cervical, thoracic spine.
yeah.
This is a great case for a quick chest, abdomen, pelvis CT. All the way, I would start it personally. I have no qualms of admitting that NASCUS2 spinal cord injury steroid protocol, and I would honestly get ready for the operating room. This is one of those cases where I'd prefer to have a biopsy. I'd prefer to follow Professor Mendel's rules, but I would bite the bullet and I would get a consent for a 2 above, 2 below posterior decompression and instrumentation.
Okay.
And stat biopsy, fresh frozen biopsy.
Anybody else have any comments? All right.
I just want to point out the sacral
Yeah.
lesion too.
There's another sacral lesion there, yeah.
I would get the carbon fiber ready.
Carbon fiber.
Sean is very happy. Extra bonus points. What about Jeremiah? Jeremiah, you want to weigh in?
I would prepare the patient, consent, and go to theater.
So, in retrospect, you know, in the military, there's always a debrief, right? Something happened, debrief, right? Just like we have M&M and QI. In retrospect, let's see, how do you go back over here? Let's see if I can go. In retrospect, how unstable is this spine when you look at this?
Yeah, I mean, I think we all were very worried with those X-rays and CAT scans that thoracolumbar junction, some acute kyphosis, no vertebral body is there really. It's completely lytic there, so
Yeah.
highly unstable.
Yeah, highly unstable. The reason why I ask you that question is because what I always say to my residents is that when you see something like this, you don't let the person who moves patients to the MRI do it, and you're not there with them. You take the patient, you move the patient to the bed, you are there with the patient, you are there to move you are there all the time, because it's the same thing with the cervical fracture dislocations, right? These are highly unstable injuries, the resident, the fellow needs to be there. I know it's tough, but you got to be there making sure that as they move, it's like everything moves together. There's no place for rolling the patient and how they do it. It needs to be spinal cord precaution throughout the entire process. Otherwise, a lot of things can happen. And in that sense, when you see that, would you take the patient to an MRI? Would you take the patient to surgery without an MRI, right? In the cervical spine, where you have fracture dislocation, somebody come in with weakness, there are those who would say, you really don't need to get an MRI, just take him straight to the operating room and realign and decompress. Is there a role not to get an MRI here, considering this being such an unstable fracture that just the risk of moving the patient to the MRI put him at risk of an injury, which is what happened here? Right? I mean, it's the same principle for the traumatic fracture dislocation of saying, are you really going to sit on a patient who's incomplete, wait for the MRI, take him with a broken neck, all of that stuff, right? With all these movement back and forth versus saying, I'm going to go in there, I don't know what it is, but I'm not going to take a chance of moving that patient more time to get this MRI, which is kind of like what happened here.
So I'm going to put my hat as a spine traumatologist on here. This is a really important point because we have to know what our institutional resources are. We're blessed with, how many MRI scanners do we have in this building? 3 or 5?
We only have 5.
I think, yeah, we have everything here. And usually a majority of them actually work, so this is kind of cool. So we can get MRIs here better than any trauma center, no disrespect to our regional trauma center. We've had patients have that same thing at a regional trauma center they used to work in, have that same thing where they were sent back to MRI for a better quality MRI. There was motion artifact, and the patients were paralyzed in the scanner. So my fascination with sagittal screening MRIs remains unbroken. We really usually don't need all the axial detail to make a critical decision of cord compromised area, yes or no. The detail is fine, but that's where the extra time is wasted. And knowing your institution and their response time, so it's getting an MRI scan, literally stat or not, the process control is very big there in terms of how patients are transferred. This patient, without a question, should have been designated unstable, and that requires a whole different set of safeguards.
So again, speaking of instability, is for something like this, do you think they should have been transported on
This is a spine injury. This
like
is
spinal
a
injury
full spine
precautions, right?
Yeah.
This is a
So
big
log
deal.
roll,
Yes.
get him on.
Yes.
Foley. My fascination with Foley.
Yeah.
Full
Yes.
bladder,
Exactly.
unstable spine gets a Foley.
That's a full-scale spinal cord injury, maintain spinal cord precautions. It won't take much before something bad happen here.
Yeah.
And so, again, that's not the kind of, if you want to get the MRI and you can get it, you got to go down there with that patient. You got to log roll them. You got to do all of that. The tech is not going to do it like this.
Well, even, it's interesting, speaking of stability, probably when you open something like this up, I mean, you can see the spine move with respiration.
Yes, absolutely.
I mean, that's to me what people,
Yeah.
they don't realize how unstable these, both thoracolumbar and cervical thoracic, can be.
Okay, so the patient is in the scanner. 0 out of 5 strengths. Who's one of the fellows here?
Dr. Menisali loves to comment.
What are the first steps you're going to go through? Yeah, we need to go to the OR, but what are you thinking? What are you going to do now?
So we have the MRI. They're now an incomplete spinal cord. Sounds like an Asia B.
Sensory level.
There is sensory level.
Asia A.
Asia, oh, okay. So complete, got it. So
Instantaneous sensory level. Instantaneous 0 out of 5 strengths.
yeah, I mean, it kind of, again, training here, but agree with Dr. Chapman, getting to the OR as fast as possible. Time is cord, basically.
Okay. Steroids?
If she's
Yes, no.
15,
Yes,
no.
No. Neil, steroids?
It'll be a long end of the year. When are you starting your job? 2026. Okay.
Well,
Neil?
steroids should be pretty straightforward. ABCs, right? Steroids, yes. Blood pressure, yes. Lumbar drain, yes.
Lumbar drain.
Whoa.
Whoa. How are you going to put a lumbar
Not
drain?
immediately, but after surgery, yeah.
No, I'm talking in the scanner. You're in the scanner right now.
Oh, just steroids and blood pressure and move her to the OR.
Okay.
But
Why
consent for-
lumbar drain after the surgery?
Consent for just for perfusion, spinal perfusion.
Okay. It's something new, but okay.
Yeah, acute injury, so we are within 24 hours. I want to perfuse the spinal cord as much as possible, so I'm reducing the intradural pressures.
Ultrasound.
Yeah,
BK ultrasound. He's the
ultrasound,
master.
every case.
He made me a convert. The BK ultrasound is amazing.
Yeah. So we could have done the case with the CT scan and would have found this tumor intraoperatively with the ultrasound, fixed it.
Okay, for the sake of time, I'm going to call on Rod now. Rod, lateral L2 vertebrectomy. Your thing. Are you going to do lateral on this quickly?
Honestly, I was thinking about that, and I think I would, given the degree of instability, I think you have to go from the back.
Okay,
So
I'm relieved.
Yeah.
I'm relieved.
yeah,
You're
but
saying.
I'm seriously considering putting in carbon fiber screws, 2 above, 2 below, and then bring her back and do a lateral. I don't think they have carbon fiber lateral expandables, but they're working on it.
Okay, so Rod already committed for a posterior 2 above, 2 below laminectomy, followed by second stage surgery, 2 surgeries.
Yes,
With a lateral, take the body out, put the cage in.
with carbon fiber.
Ian is going and doing the back, you go and do the front, 2 for 1, done.
Actually, we do that a lot.
Yeah. Okay. All right. Go ahead. What do they do in Kenya? In Kenya, you don't have
so
that
in
lateral
Kenya,
approach. So what do you do in
We do
Kenya?
not have the luxury of getting an MRI just when we need
Ah,
it. It
there
will
you go.
actually take days because most of the hospitals do not have an MRI. So the bookings are long. And if it's a weekend, that even makes things harder. Just looking at the first image, already even just going by like Tillich's classification, this is already unstable fracture. You can see the posterior ligamentous, discal ligamentous injury is already there. So the best thing is just take to theater or OR in North America, take to OR, decompress from behind, and then now we can actually, since intra-op, you'll be able to see that. And then now we can plan for the second surgery to come like anterior.
Okay.
Yeah.
Neil, what do you tell the family?
We will.
The daughter is there in the emergency room. She brought her mother because she was having back pain walking. Now you're dealing with that situation. What do you tell the family?
Well, I usually say 1% chance just from anesthesia of stroke, paralysis, coma, and death. In addition to that, new acute onset paralysis, the prognosis is guarded, but we will go in and decompress the neural elements. We'll send a pathology
So what do you think
specimen.
the first thing she's going to ask you?
What
The
happened?
daughter in the emergency room.
What happened? Right.
What happened?
Yeah.
You need to figure out a way to answer that.
Yeah, she presented with an unstable fracture that became unstable in front of our eyes, right?
Okay.
And she has acute new compression due to this fracture that she presented with that we need to go fix.
Okay. Anybody else have any comments? How they're going to address the family and how quick to take it to surgery? Anybody going to go in the front first? This is an anterior pathology. This is anterior compressing the spinal cord from the front. And all of you are saying you're going to go from the back?
Yeah.
And the reason?
I mean, I think it's pretty unstable, so I would.
You can stabilize it from the front.
You can.
Yeah. So why
Yeah, I
would
think
you
it's an
not go
option.
from the front? You can stabilize
Yeah.
it, put your nice cage in there, the plate.
You
It's going to
can
stabilize
definitely
it.
do that. I think that's an option.
So why not going from the front?
You said it was middle of the night, so
Yeah.
it's hard to get the instruments, the team. It's much quicker
Okay.
just to go in, and I think if she wasn't paralyzed, I would consider going in from the front.
With the less invasive surgeries, I found there to be a technical problem, even in the hands of a master, and that's decompressing the dural sac
Yes.
reliably. Getting a clean margin of the PLL relative to healthy vertebral body above and below the lesion is surprisingly hard. You don't have the angles, the tools are difficult. A lot is done with proprioceptive assumptions and not with real visualization.
Yeah.
From posterior, this is not any problem by going posterolaterally without any retraction of the dural sac to get a complete left to right cleanup, making a big cavity in the front of this, and then having your partner do the easiest ever. And if you want to be really nice, you can take out the far lateral vertebral body even on the left side because he likes to go from the left. So he has literally a clean shot to put that cage in. Sorry, I took your
Yeah,
microphone away.
no, I was going to say the exact same thing. I agree with you with just doing a posterior approach is, the number one goal of this is decompression and stabilization. And so if you go from an all posterior approach, you're going to do your very quick laminectomy and you're going to already be well decompressed there at the conus. And then once you can see that dural border, it's very easy to kind of drill down that pedicle and get some of that ventral tumor off.
Okay. Any of the residents have any other thoughts? Any of the residents will do it from the front first?
Dr. Gold? Dr. Gold, Iowa.
Fellows?
It's a long year for you two. Here.
While they're trying to figure it out, I would say, keeping in mind tumor principles, we don't have a workup. We are concerned this is some kind of oncologic problem, seeding two cavities or going from the front without knowing what this is, I think is high risk. So that would be why I would stay posterior based only.
So I think, go ahead, Neil.
We also, this is a brand new trauma as well, so we don't know what's going on in the abdominal cavity. Yeah, and if it's a renal cell or something and you go in and it bleeds all over the place, you have no control.
So yeah, that could be potentially a very vascular thing. Would you ready to go to the OR? Would you preemptively embolize it, thinking that this potentially can get you into a lot of trouble? Would you spend the time, she's paralyzed, she's not moving, embolizing it? No. Okay. All right, I finished playing devil advocates with all the other options. But you would be amazed to find out how many surgeons will attack this from the front. Why? Because the pathology is, or many cases, even elective cases, will go from the front. In my mind, cases like this has to be done from the back first. Why? Number one is there is a extremely unstable spine. You're going to have to go along. Number two, there is spinal deformity here. In my experience, correction of spinal deformity is much better with low construct from the back versus an expandable cage from the front. So if you are in the business of trying to correct some of this deformity, opening the space in order to get something there, the correction of the deformity with multi-point fixation from the back, much easier. I don't rely too much on deformity correction by expandable cages. Number three, going from the front, when you do vertebrectomies with Rod or anybody else, and you go in the front, it's not about putting the cage at all. You can show great x-rays with cage placements and all that. It's not about the instrumentation. What is it about? The decompression. The decompression. It's about the tumor resection. It's about finding the PLL, get your number 4 pin field between the PLL and the dura and get all that stuff out. If you just take the bone out in order to put a cage there and you left all that stuff behind, you have not done the surgery you need. And so to establish the right planes of where is the dura, where is the tumor, it all can be done from the back. It's going to be very easier for somebody like Rod to come then later from the front. Once all that stuff has been cleaned out, his job is only to go in and put the cage because all of that stuff has been taken out. But to go up front from the front, the hardest thing about an anterior surgery without surgery in the back is finding the dura, is finding the ligament, is getting all that stuff out. It's not about the instrumentation. The instrumentation is a given. It's getting the pedicle drilled, it's finding the nerve root, it's finding the dura, it's peeling off all the PLL. In tumor cases, you need to get that stuff out. You can't leave it behind just because you got enough space to put the cage. In fact, if you put a cage there and you have not taken the PLL that is infiltrated with tumor, you will push some of that PLL and tumor back into the canal. So for me, the hardest thing about an anterior approaches is decompression, is finding where the dura is and then take all that PLL off. And that's hard to do from the front. That's where I spend most of my time. Once the PLL is off and the dura is decompressed, putting the cage is a slam dunk. The time needs to be spent is to finding where is the dura, drilling the pedicle, all of that stuff out. So with this situation, do you have time to do it? No, you want to go in the back, you'll find your planes. And so that's in essence what we have done. And that's kind of like the way it looks like at the end. With a cage in the front, I went 2 above, 2 below, just for the sake of time. And that's
what was the pathology?
The pathology was multiple myeloma.
That was I was going to say.
Yeah, so again, multiple myeloma is the kind of tumors that I typically do not like to operate on because the bone quality is terrible. Multiple myeloma cases rarely need surgery. I don't know if it's a surprise to you. Multiple myeloma cases rarely need surgery. And a lot of times, if you end up putting a lot of screws in there, if you're not supplemented, you're putting screws into a drywall. You're not putting screws into the stud. Every time you put a screw, you want to make sure that it squeaks, right? You put a screw into a stud. Multiple myeloma, you keep putting those screws and they go on empty. And you know it's not going to hold. So multiple myeloma is really a lot of medical entity type disease. A lot of fractures with multiple myeloma, I treat with vertebroplasty for fractures. I don't go and put screws and everything else because they come back, the screws get loose. And I just don't want to deal with it. So anyway, we ended up doing this for her, and it turned out to be multiple myeloma. And she recovered all function, by the way. Walked out of the hospital within, I think, 3 weeks. So,
Question. So hypothetically, if you go back to the initial studies, SIN score, you're one of the masters of the SIN score. You're one of the originators.
yeah.
If you go back again, how did this patient rate on the SIN score? She did not have pain, you said.
She had pain.
Oh, she had pain.
She came in for pain.
She came in for pain. Okay.
Yeah.
But that
I think it was 13.
No neurology. So why did you not include neurology in the SIN score? We've asked that many times. How come one of the most cardinal things that you grilled me on in my lady with the urinary retention? Okay?
Somebody got to give you a hard time, Jan. Who else
All
gonna
the
do it?
time. You have no idea. Everybody here gives me a hard time, but except for Jeremiah. I really like Jeremiah. He's very nice to me. No, but seriously, why did you not put in a neurologic score if that's so important?
We should have. I think that's a critical thing. But neurological exam on a score, you have to put the type of Asia that will be one of those other things that fits into it. But we focus on mechanical stability. We focus on this again. The scale is not for neurosurgeons and orthopedic surgeons. It's for the radiologist looking at the film and say, that looks unstable. I need to get the goal was not to, we know what we need to do many times when somebody come in with a neurological deficits. It was meant for the family practice guys who look at the reports or the radiologist to look and said, it looks like an unstable fracture, and somebody just walked into their clinic. That was the goal. I think the neurological aspect is a given. If they come in and they're not moving one leg, we already get cold. It's really what was not meant for us, even though we use it.
So you think
Where would she have scored? Just out of curiosity, how high would she have scored? Did she have bilateral post-element disruption?
Yes.
Yeah. So she would have a high score.
Yeah, very high score.
Okay.
I think it was like the top, maybe 14 or 15. Yeah.
Steroids? Did she get steroids?
I did.
Yes,
I'm
my man.
because it was such an acute thing. It happens in front of our eyes. I saw no problem with that.
By the way, I want to, again, make a pitch here. So, Nick, you're on close watch here now. All that data on the higher complications with NASCUS steroids identified wound infections, pneumonia, and higher DVTs for some reason as the only complications. Oh, stomach ulcers. No, the third was stomach ulcers. That's nonsense. They did not get proper modern ICU care. I mean, all of those threes are very easily navigable with modern rapid mobilization, pulmonary care, anticoagulation, and whatever you want to do for H2 blockade.
100%.
This is poor care, right?
Yeah.
And good wound closure.
Yeah. I use plastics. My plastics are good friends of mine. I am very aggressive with my plastic utilization. I've published a lot of it. Not in this case, but I'm saying just in general, on a lot of these cases, I operate on a lot of patients who have been radiated before, and so wound healing is critical. So don't be afraid to call your plastic colleagues for a lot of these cases. All the cervicothoracic junction cases, even non-tumor cases, the likelihood of wound breakdown just from the patient moving their shoulders is high. I get plastic to close all the cervicothoracic junction, whether it's osteomyelitis, trauma, tumors. I'll end up using coming and closing the wound. So in that case that Jan showed, I would have used plastic for a wound closure.
Wow.
Yeah.
Here's a question. So, in a case like this,
Can we use a microphone? And tell us who you are.
you can't hear me?
The people online, I don't know how many are online right now, but there are probably 80 online.
Hi, I'm a Sean Bro with the CarboFix. I just had a question. So now that you've done this, would you consider going straight to the OR versus going to an MRI first? I mean, like if you had a fresh fracture, it's obviously I mean, obviously unstable. She's neurologically attacked. Would you consider just going right to the OR, or am I still going to get the MRI?
That's exactly the question that I asked. I think that in a setup of trauma, maybe not going to the MR just because I'm worried about moving the patients too much. But that looked like tumor to me, right? It looks like tumor from beginning, moment one. If you look carefully, there's a big lytic lesion at that L1. Tumor changes the entire spectrum, right? Now you have no idea what you're dealing with. There's one lesion, two lesions, cord compression, where is it coming from? And so when you suspect tumor or infection, I err on the MRI. But I'm taking a risk. I'm taking a risk of moving the patient from one bed to the next, from that bed back to the bed, all of that stuff. When I see that, I'll tell the fellow, the resident, you go with the patient. You look, nothing else matters. That is your only patient for that night. You go with them, you examine them before. As you move them to the MRI, you keep check that the legs are moving, right? As you move them from the bed to the MRI, they come off the MRI, you make sure you are in control with the text, log roll the patient, move them spinal cord percussion all the way, re-examine the patient, because it doesn't take much for a little movement and it's done. So as long as you can set it up the right way and the level of suspicion is very high, I think an MRI, in this case, absolutely. All right, guys, thank you.
Nice case. Yeah. Crossover. So what's next?